Our first speaker is Dr. John Stone. Dr. Stone received his education in the UK with degrees in chemistry, mathematics, and physics. John came to Canada as a postdoctoral fellow at the National Research Council. His career was at the federal government, where he worked with the NRC, External Affairs and Environment Canada. John ran the Federal Climate Research Program for several years and advised ministers on the issue of climate change. He served on the Bureau of the Intergovernmental Panel on Climate Change, the IPCC, for the third and fourth assessment reports, and also worked for the International Development Research Center. John retired in 2005 and is currently an adjunct research professor at Carleton University in Ottawa. So John, if you'd like to come up to the front. And forgive me, I didn't introduce myself. I'm Heather Stewart. I'm the program chair for the Friesen conference this year.
No, I've got one. Okay. Good morning, and thank you for inviting me. We've now gone right to the end of the slides by the looks of it. How do I go back? I only with this one? All right. Okay. When I was invited to come to this event or series of events, I first in my mind the literature that I knew of, and I wondered to myself how we were going to spend 2 or 3 days, that there wasn't a lot to actually say. But yesterday I was fortunate to be invited to be part of a think tank with a lot of exceptionally bright and knowledgeable people, and it opened up huge vistas to my mind of possibilities, opportunities, and threats. And I think we're at the beginning of a rather exciting period of both research and action. But what I would like to do this morning with you is to explore the science of climate change and its implications for an aging population. I will try to explain why climate change is a broad threat to our society, to the economy, and to the environment, and how the climate is likely to change in the future. And I will focus particularly on what we expect to be an increase in the frequency and the severity of extreme climate and weather events which are a particular threat to older people. Let me start with what is the root cause of the problem. As you all know, we are fortunate to live on a planet which has an atmosphere. An atmosphere which is not very thick, a layer not much more than about 18 kilometers from top to bottom. And it contains vital gases. One, of course, being oxygen, which allows us to breathe and maintain our existence. Another being water vapor, for which we ultimately depend for the rain, for our agriculture, for our forestry, for our livelihoods. But also a series of gases which are called greenhouse gases. And these act as a kind of a blanket around the Earth, and they keep the Earth warmer by about 30 degrees Celsius. So we know that these greenhouse gases affect the climate. The problem is that the concentration of those greenhouse gases in the environment, in the atmosphere, has been growing. Has been growing mainly because of our burning of fossil fuels and the free dumping of that waste into the atmosphere, but also through such things as deforestation. This graph, I hope you're all comfortable with graphs, shows what's happened to the concentration of carbon dioxide, an important greenhouse gas, in the atmosphere over the last 50 years or more. I could give a whole talk on this one graph because I think it contains so much information and so many lessons. So here is the concentration of carbon dioxide in the atmosphere, and here's time. Before the Industrial Revolution, when we relied on human and animal power rather than fossil fuel-driven power, the amount of CO2 in the atmosphere was about 280 parts per million, just below this graph. But since the beginning of the Industrial Revolution, we've been burning fossil fuels, whether it's wood or coal or oil or gas, and so the concentrations have been increasing. The wiggles that you see on there are the Earth breathing. In the summer, when everything turns green, all that biology draws carbon dioxide down from the atmosphere, and so the concentration level drops, and the opposite happens in the fall and the winter. So you see that this concentration level has slowly increased inexorably. Charlie Keating, whose data this comes from, measured this in the atmosphere above Mauna Loa in Hawaii, starting about 1957. 1957, climate change was not an issue. It was on nobody's scientific or political agenda. And he sort of observed, even over a period of a decade or so, that concentrations were going up. And scientists began to be concerned with climate change, way back in the early 70s. So climate change is not a new issue. And scientists kept on telling governments that this was something they have to pay attention to. And eventually, in about 1988, they started to act. 1988 was an interesting year because there were heat waves, droughts in North America. It was one of the warmest summers on record, partly driven by an El Nino. And so they created the Intergovernmental Panel on Climate Change to provide governments with well-balanced and useful, accessible assessments of the state of science. The first report of the IPCC convinced governments that they had to take action, so they created what is called the United Nations Framework Convention on Climate Change. And so the story goes on. The story being that regardless of all these meetings and all these good words, lots of sound and lots of fury, the amount of carbon dioxide has increased and increased and increased. We can't ignore that. So if the concentrations have been going up, and as I said earlier, we understand why those gases, those greenhouse gases, carbon dioxide, for example, affect the climate. Has the climate changed? Let's look at temperature. It's the easiest thing to look at. So here's another graph where this is temperature departures from a baseline. It doesn't matter what we choose. And this is the time here going up to almost to the present and going back about 150 years. And what you see, these black dots are rather gross averages. They're globally averaged, annually averaged temperatures for each year. And you can see they go up and down. There's a certain amount of what we call natural variability in it. In some years, the trend is down. But what's really interesting is if you sort of take the whole 150 years of temperature records, these are observations now. It's a sort of empirical evidence. The last 150 years, you get this red straight line. If you only use the last 100 years, you get this purple line. If you use the last 50 years, the amber orange line, the last 25 years, you get the yellow line. And what this is telling us is that the closer we get to the present, so this slope gets steeper and steeper and steeper. In other words, that this change of temperature, this change of climate, is accelerating. It's getting faster the closer that we come to the present. We can see already changes in the climate elsewhere. For us in Canada, perhaps what's the most dramatic is what's happened to the sea ice in the Arctic. It's declining, and it's declining faster than any of our models were projecting. In 2007, we saw the lowest amount of sea ice at the end of the summer that we've ever seen, certainly during the era of satellites when we could have a whole comprehensive picture. By some estimates now, we could see an ice-free Arctic by the end of the summer period within the next 2 decades or so. That's already affecting the lifestyles and the lives of the Inuit and other indigenous people who live close to the Arctic. The ice sheets in Greenland and in Arctic and Antarctica are also melting faster than we thought before. In fact, we've been forced to rethink our understanding of glacier physics. And as a result, the current projections for sea level rise as a result of the melting of the Greenland and Antarctic ice sheets are probably twice as large now as they were when the IPCC produced its latest report in 2007. So all of that's empirical evidence to say that climate change is already happening now, and it's a real and a present thought. What's going to happen in the future? Now, of course, I can't tell you exactly because I don't know how the future is going to evolve. I don't know how our demand and our supply of energy is going to change. I don't know exactly how the population is going to change. I don't know what technologies are going to be available. I don't know if we're going to maintain the same inequities between the poor and the rich, or whether we're going to have some new geopolitical world out there. But we have some sense of where we're going to go, simply as an extrapolation of where we are today. So the Intergovernmental Panel on Climate Change produced a series of scenarios. They call them emission scenarios. These are scenarios which projected what the future emissions of greenhouse gases might be, based on sort of what-ifs, all of them equally plausible. And you can feed those into our understanding of how the climate works, and through some of these models. And you can make some projections into the future. We call it projections, not predictions, very carefully, because while we can have a very good idea generally how climate will evolve, I can't tell you exactly where the impacts will be greatest, when they will happen, and who they will affect. But because already we see this increase of the driver of carbon dioxide, we know the climate will change. And so that's what this says. Here are 3 of those scenarios. The black line is the observations up to as latest as we could go, and then we let the climate models take over. Carlos showed this similar diagram in his talk, and the spread of these future projections by the end of the century is somewhere between 2 and 4 degrees Celsius. An average, you might say, somewhere along here is about 2 or 3 degrees Celsius. The rise in temperature during the last century was about 0.7 degrees Celsius. So what we're looking at here is a projected increase of temperature that is 4 or 5 times as large as the increase of temperature that we saw over the last century. But there's something else I want to say about it, and Carlos mentioned it, and that's this, in my graph, this purple. This is what would happen to the temperatures if today we could keep all of the concentrations in the atmosphere as they are today, which means no emissions. Of course, that's practically impossible, but this is a sort of a thought experiment. And what you see is that the temperatures continue to rise. They continue to rise because of the inertia of the climate system. So like a sort of a bowling ball, when you launch it, it keeps on going under its own inertia. That inertia itself is going to give rise to an increase of 0.1 degrees Celsius per decade. But it's not the only inertia. There's also an inertia in the drivers of climate change, how we produce energy, the cars we drive, the generating stations we have for electricity, and all of those sorts of things. We're not going to change those overnight. So there's inertia there. That's going to add an additional 0.1 degrees Celsius per decade. And all of that is because of the inertia in the system. That is now inevitable. As I say, that's part of history is now already written. We can't avoid it. And it's going to mean that there are going to be certain impacts which are now inevitable. And it's going to be imperative that we adapt to those. Population has its own inertia. And we saw that in some of the graphs that Carlos wrote. That we already know what the population is likely to be in the future because of the people who are already here, the people who have already been born. We can't ignore these inertias. And so that's, this question of inertia, whether it's in the demographics or in the climate, are things we have to seriously take into consideration. So what's it going to look like for Canada? Very quickly, we're going to see more warming the closer you get to the Arctic. We're going to see more warming in the interior of the continent. And we're going to see most of the warming in the winter and fall. And of course, this change of climate is going to affect health in many respects, and particularly the health of older people. We already have some good idea of what these changes might be. We know, for example, that disease vectors are likely to change. And one impact that's been discussed quite a bit in the literature is the northward expansion of the Lyme disease vector, with a 2 to 4%, or 2 to 4 times an increase in the abundance of the ticks. To my mind, we should be able to cope with that because we have a good public health system in Canada. But that's not likely to be the luxury of people everywhere, and particularly people in developing countries who are going to suffer probably most from an increase in malnutrition as their locally produced crops suffer greater water stress because they're not going to have as predictable rains as they used to have. And that's going to be on top of the existing poverty that these people have. Older people are typically more vulnerable to some of these changes in climate because of reasons of health and the availability of resources. One of those which we've been discussing is what will happen to people as a result of the increase in severity and frequency of extreme weather and climate events. My point in talking about disease vector changes, agriculture, poverty, malnutrition, water security, is that you've got to consider all of these different stresses, not just climate change alone. It's not just a smooth rise of temperature. It's lots of other things. And I think that's a really important point to remember. If climate change was only a smooth increase of temperature, we have some sense that we could probably adapt, we could probably manage that. But it's not going to be. There are going to be these extreme events. We know that by simple statistics and by straightforward, well-established physics. And we've already seen some evidence of that. The worry is that although these extreme events may be short in duration, their impacts can be long-lasting. Not just the physical impacts, but the impacts on people, on societies, and on their psychological well-being. We've already seen evidence of extreme events. One of the ones that many people will refer to is the summer heat wave in 2003 in Europe, which was to some extent repeated last year in Russia. And this shows you where there were the most additional deaths as a result of that heat wave. The numbers are still, I think, uncertain, but it's at least in the order of 40 to 50,000 additional deaths as a result of that heat wave. How unusual was it? Well, this is a sort of a little bell curve graph of the observations over the last 150 years or so for the centre of Europe. And every one of those vertical lines is the temperature of a particular year. Here's 1909, this is 1947, but you can see that if they all clump together and you can put them under a curve like this. 2003 was out here. It was clearly outside this range of normal experience. And that makes some sense. We can take our models, which we have increasing confidence in, and take the same period, and knowing what the drivers of the climate have been over the past, and we can get a quite reasonable, similar shape of the graph. Supposing then we take those models, which, as I said, are not bad at representing the past climate, and make the projections to the future, given what we expect from the drivers, those scenarios that I showed you, then we start to see a change. We start to see the whole set of data moving to the right, and an extreme event like we saw in 2003 now becomes much, much more common. If you look at some of the science, you can't say that any one particular heat wave is due to only anthropogenic, human-induced climate change. What you can say is that the likelihood of it happening increases because of what we've done to change the composition of the atmosphere. That the heat wave in Europe in 2003 was twice as likely as it would elsewise have been. Let's translate that into what it means for sort of some of us. And just look at warm events in Canada. Suppose we define a really hot day as one that those temperatures are about 33 degrees Celsius. Today, it's said here 1985, but that's close enough, we expect to get that 33-degree heat wave about once every 80 years. That's how often it will return. But with climate change, by the middle of the century, we're going to see that temperature at least once every 10 years. And by the end of the century, probably once every year. On the other side, we're going to see less cold events. Such that today, a cold event which we can define again, let's say it's minus 33, occurs once every 10 years. By the middle of the century, it's going to occur about once every 80 years. So that sounds like a good news. But some of the recent research suggests that even though the frequency of these cold events is going to be smaller, they could be much longer lasting. We don't know at the moment whether, for health reasons or not, we're going to see more people die as a result of the increasing number of heat waves, or less people as a result of the decreasing number of cold waves. Nevertheless, it's certainly something that cities, communities have to take into account. And especially if these things are going to repeat more often, recovering from any one of these takes time. And if a second hurricane, tornado, flood, heat wave happens before you've really recovered, it puts enormous stresses on individuals, on society, on communities. And we've seen that. We've seen that, for example, in Canada, in the Red River, where we've seen a decreasing number of flooding events, that it's really affecting the psychological health of a lot of Canadians. So I think with that, my time is up, and I'll stop. Thank you for your attention.
Okay, so next we'd like to welcome Dr. Gloria Gutman. Gloria developed and directed the Gerontology Department and Gerontology Research Center at Simon Fraser University from 1982 to 2005. She really needs no introduction to some of you. Gloria served 2 terms as president of the Canadian Association on Gerontology, was president of the International Association of Gerontology and Geriatrics from 2001 to 2005, and currently is president of the International Network for Prevention of Elder Abuse. In addition, Gloria is a director of the International Institute of Aging, UN Malta, and a member of the World Health Organization's Expert Advisory Panel on Health and Aging. She is author or editor of 22 books and monographs and over 150 scholarly articles, reports, and chapters on seniors' housing, dementia design, long-term care, health promotion, aging and technology, and seniors and emergency preparedness. In 2007, Gloria was awarded the Order of British Columbia for her pioneering work in gerontology. And in 2010, she was awarded an honorary law degree by the University of Western Ontario and named one of Canada's best 45 over 45 by Zoomer magazine. Gloria, please come to the stage. And Gloria is going to give us some background on the aging phenomena globally.
Well, good morning, everybody. Most of us are familiar with this diagram, which shows Canada's changing age structure. And what I want to do this morning is to give a little bit of the background to some of the statistics that Carlos presented, and to just remind you what population aging means, why it occurs, where it happens, and what are some of the real costs and benefits of population aging to society, and what our lead time looks like. And finally, what we need to do to achieve a society for all ages. Just to give you a little background, we used to talk about a society as being old if 7% or more of its population were aged 65 and over. In the last 10 years, we started talking about a society as old if 14% or more were 14% were age 65 and over. These days, there are a number of countries that are already at the 20% mark. So we're using different benchmarks. As you see on this slide, the annual increase in the population 65 and over is larger than that for the general population of the world. And currently, 24 out of 25 of the countries with the highest percent 65 and over are in Europe. But it's quite clear that many people age 65 or 60 and over, which is the number, the age that the World Health Organization uses to mark entry into old age, that many of those people are living in the developing world, and that by 2020 we're going to have over 1 billion 65 and over, and the majority of them will live in the developing world. So just to show you on a little different map, this was one for 65 and over in 1990. The darker the blue, the higher the percentage of old people. And the really dark blue is, the legend says 13% or more. When we take a look at 2025, we see that there's going to be a lot more countries that have high percentages of their seniors who are old. And it's interesting to note that whereas it took countries like France 115 years to go from the 7 to 14% mark, Chile will do it in 30 years, China will do it in 27 years, Singapore in 21 years, Tunisia in 15 years. So we've seen a lot in the news these days about the Arab world and changes in it. And there's talk about the youth bulge. The fact is population aging is happening there, and it's going to happen very fast in a very short period of time. Now, why does population aging happen? And what are some of the what are called the epidemiological transitions? Well, from the point of view of health, the first thing is that there tends to be a decline in deaths from infectious diseases and more chronic disease. But it's caused by two simultaneous trends. The one is that more and more people live to be old, and the second is that there's a drop in the birth rate. The birth rates of the major advanced countries have been dropping for some time. This is the total fertility rates, average number of children born to a woman during her lifetime, and if you just look at the changes from 1970 to 2010, we see that there are a number of countries in the G8 countries that have gone from replacement level to well below replacement level. And I was just at a conference in the UK last week where there is major concern that countries are going to see declines in their total population because the young people are not making babies anywhere near the rate they did before. And it seems quite unlikely that we are going to see the large numbers of children being born that we saw in the past. Because the vast majority of married women are now using modern birth control methods. And particularly in East Asia, we see 80% of them are now using birth control methods. So this means that we're going to have to find ways to entice young people. Paying them doesn't work. France tried it, Quebec tried it. The Scandinavians have been successful in bringing their birth rates back to replacement level by putting in some really good child care provisions. Because women are saying, if we're going to have babies, we have to also be able to carry on with our life, do other things. We've got more women than ever before in the labor force. And once they get out of the kitchen, get unchained from the stove, they're not going back. In terms of the Asian situation, as we heard, Japan is the country that has the most old people. But we want to remember that the seniors of today are really quite different than their ancestors. And see, gerontologists are interested both in population aging and in individual aging. And so my job this morning is to remind you of that fact and to say, Whistler's mother didn't live to the kinds of ages that we're seeing people live today. People are living much longer, and you can see this is British Columbia. So between 1931 and 2001, in the case of males, there was a 15.8 years gain in life expectancy, and in the case of females, 17.5 years. So we've got people living these days in this province, men to about 78, women on average to 83. So you can figure, if you're in this province, that you're probably going to be around for quite a while. And reflecting the epidemiological transition, they're generally physically healthier than their moms and their grannies, less likely to die from infectious disease. But we really have to be careful to recognize that seniors are not a homogeneous group. And so when somebody says, well, the elderly do this or seniors do that, we really have to be concerned, to ask some questions. We also have to be beware of apocalyptic demography, which is the idea that somehow society is going to be swamped because we have a bunch of people living to be old, or that they will break the bank with their demands on the healthcare system. Tina looked pretty good, right? So one of the things that underpins apocalyptic demography is this idea of that somehow the older population are a homogeneous group. But it depends on what political person you're talking to, whose axe is being ground, as to whether they give a picture of most old people as being sick and poor and making these huge demands on the healthcare system, or sometimes they make it sound like they're all rich and healthy. So therefore, we don't need to support them, we don't need to worry about them, and we can cut back on services. I mean, these are some sort of interesting ads. And particularly with the boomers, there is this idea that somehow the boomers are all going to be beautiful and healthy and rich. We forget about the soft underbelly of the baby boom generation. The people who were decanted from some of our institutions, the Vietnam veterans, the various people within society who don't have it so good. In Canada, poverty rates have gone down considerably since 1980, so that for a couple around 2001, about 6% were at or below the poverty level. However, if you disaggregate the data by sex and by marital status, we get a quite different picture. And what we find is for unattached persons in Canada, as of 2001, and the data is about the same for 2010, it may be a little worse, but about half of the unattached women, 65 and over, are at or below the poverty level. So it's not all glowing and great for people that are growing older in this country. So, we think about poverty in the developing world, we need to also remember that there are pockets of poverty, and one half unattached women, which means widows, separated or divorced people, or some of those who have chosen to not to marry, that in this country we still have half that are at or below the poverty level. So key individual difference variables that we need to consider when we're talking about the elderly are gender and culture. Those are two cross-cutting variables that are very clear in the WHO literature need to be taken into consideration. Aging is different for men than it is for women. There are differences in our biology, there are differences in our physiology, there are differences in our social way of growing older. Housing and living arrangements are different within the seniors population. And it may surprise some people to note that within the 65 and over population, we've got about 7% at any point in time who are sufficiently debilitated that they require to live in a collective dwelling, which generally translates as nursing home. But the rates of entry into collective dwellings vary depending on whether you're what is called the young old, 65 to 74, the middle old, or the older old. And so your odds of living in a collective dwelling go up considerably if you're surviving past age 85. But it's interesting because the vast majority of seniors are living in the community in private dwellings. And in that 65 and over group, the vast majority of people, most of the time, can do what they want to do. So we've got a subset who are frail and that we need to protect, but it means that we've got 85% who can be resources for their families, for their community, for their country. Now, we're going to see more diversity in the future. We're already seeing more people with HIV/AIDS who are surviving to be old. With the drug cocktails that have been concocted, people are able to survive what was a disease that killed people very quickly and at a young age. The same thing is true. We are already seeing people with congenital and acquired mental and or physical disabilities living into old age. So there are a number of other things that underpin apocalyptic demography. One of them is age blaming, to sort of blame the fact that, and this is a really interesting one, the last recession was blamed on too many old people making too many demands on the healthcare system. That was about 10 years ago. Then things got better, the economy was in the black, so it doesn't compute. When you've got more old people and yet your economy was good, it doesn't make sense that they were the reason that the economy did what it did. Now, we're into another recession now, which has been used as an excuse around the world by many governments to cut back, particularly on preventive services. So the message I'd like to leave at this point is that we have some lead time in terms of thinking about seniors and the effect of climate change, the effect of other things that we might talk about, and to achieve the society for all ages. This shows you that within the boomer generation, for example, the first group, in 2011, turned 65. But we've got generations within the boomer generation. So not all boomers are alike. We need to consider the determinants of health in talking about the various factors that will have an impact on how seniors age. We also need to consider period and cohort effects, the historical period in which a person was born, and as they move through the life course. So gerontologists say you have to take a life course approach, meaning what you are when you're old is a product of what you were when you were young. And there's the old story of the fellow who lived to 92, and he says, if I knew I was going to live this long, I would have taken better care of myself. Right? So, I mean, that is something that is very clear. So gerontologists are interested not just in old people, but also in people from 18 and over, adults, and it's adult development and aging, because, as we say, we're concerned that we need to make sure that people are healthy when they're younger so that they will continue through life to be healthy. And we've seen changes in the last little while in the average age of retirement. In a number of jurisdictions, they have now removed mandatory retirement. We're going to see more people staying in the workforce. These two gentlemen, this fellow boasts a career of 55 years as an engineer, and he's still working. This was in Japan. And this other fellow is a senior who is a very active volunteer, but both, this fellow is well into his 90s. So we're going to see quite different seniors, and we need to keep remembering that they aren't all sick and frail. Thank you.
Okay, so thanks a lot, Gloria. That was terrific. Our next speaker is Mr. George Tikeski. George is Senior Director of Community Relations at Hospice by the Sea, a not-for-profit community-based provider of hospice and palliative care, caregiver support, bereavement counseling, and home health agency services in South Florida. In his position, George oversees the Fund Development and Communications departments. He has over 15 years' experience working in the healthcare industry and was previously Vice President of Community Care Services at Alzheimer's Community Care, Inc. From 1998 to 2005, George served at the Florida Department of Elder Affairs as a government operations consultant and as one of the agency's emergency coordinating officers. In this capacity, George worked directly with Florida's healthcare policies and regulations, specifically in the fields of housing, long-term care, and disaster recovery. In 2004 and 2005, when 7 hurricanes made landfall in the United States, George was recruited and deployed as a member of the United States Administration on Aging Disaster Response Team. In 2005, he transferred to the Florida Department of Health and was responsible for overseeing the state's Special Needs Shelter Program. To date, George has been deployed for 9 federally declared disasters and is recognized as an accomplished speaker, educator, and materials author, for which he has received several meritorious awards and recognitions. And George is going to give us a very interesting talk about how climate change will impact the most vulnerable of older populations, using some real-life examples and experience.
Good morning, and thank you, Heather. I'd like to thank Heather, the organizing committee, and SFU for having me here. It's a real pleasure to come back up to Canada. I've been here several times to talk about some of the things that we encountered with aging populations and disasters, natural disasters. I also want to thank John and Gloria for their very informative presentations and for providing all the charts and graphs, which my presentation will not include. What I'm going to try and do is tie the two pieces together, the two earlier presentations, through personal experiences with what happened in Florida and in the United States, and specifically give you from a on-the-ground perspective how seniors, and particularly the most vulnerable of seniors, were impacted by significant weather events, which we anticipate will increase as a result of climate change. The various different events that I will be discussing include really 8 hurricanes, 7 of which hit Florida. Hurricane Rita came into Texas, and the 2008 Iowa floods. And although these are hurricane-based events and one flood, a lot of the things that occur during these types of disasters are applicable across the board with really any type of climate-based or major significant weather events, whether it be a fire, whether it be a flood, tornadoes. We've seen several tornado issues just recently, heat waves. The lessons that we've learned from each of these storms and the things that we saw happening as a result of these events really apply across the board. When we talk about the elderly population, and we've been talking about the elderly population over the last, or yesterday as part of the pre-conference think tank, and in other conferences and other meetings that I've attended, we sort of look at older populations in a very specific and general format as, you know, you're either over the age of 60 or 65. What I'm really going to focus on are vulnerable elders. Age with respect to disasters and major significant weather events is not necessarily a good determining factor for vulnerability. And so this perspective is really coming from an emergency manager's perspective and not necessarily an individual who is in the field of gerontology. Who are our most vulnerable adults in a catastrophic situation? They are the frail and disabled. They are often dependent on O2 or electricity to maintain themselves, to be able to remain in the community or the environment that they live in. Alzheimer's patients, in 2004 and 2005, we saw with Florida having such a high prevalence of Alzheimer's that patients with Alzheimer's and related dementias were really vulnerable in a catastrophic event. And became a real challenge for emergency responders to identify, to work with. And so this population, of course, being age that is the greatest indicator of Alzheimer's, with the aging population, we anticipate seeing a lot more individuals that are at risk because of Alzheimer's in weather-related events. Of course, our institutionalized elders, the elders that are requiring medical care on an intermittent basis or on an ongoing basis, are at risk during disasters. And then individuals that are in the community that require supportive services. As I talked about yesterday, there are many, many elders that are living in our communities that are not in hospitals, not in nursing homes. They are there because all of our healthcare policies, all of our efforts to minimize institutional placement and costs associated with institutional placement has really pushed everyone back into the community and overlaid supportive services, healthcare services to keep them where they want to be. That's where we want them to be. But in a disaster, those services are stopped, and so therefore they become highly vulnerable. Also, economically disadvantaged individuals. When the levees broke in Louisiana and New Orleans after Hurricane Katrina hit, who was left behind? It was generally the individuals that did not have the financial means or the ability to get out of harm's way. And so in a disaster, if you do not have the resources, a car or even the bus fare to leave your area, you are a vulnerable, at-risk individual. We have socially isolated individuals, individuals who either choose to be socially isolated or have become socially isolated due to various different factors. And these individuals, especially in rural areas, are often hard to find and hard to get services to, especially emergency services. And then another individual or another group that I like to include is probably all of the above, but also require the care of a caregiver. And I'm not really talking about paid caregivers. I'm talking about, in most respects, elder spouses. For emergency managers, when you're looking at vulnerable populations, they're either by themselves and probably receiving supportive services, or they are with a caregiver who is often frail and elderly themselves, generally the spouse. And so when you're planning for any kind of response to a climatic event, you really have to think of not just the vulnerable adult, but the vulnerable adult's caregiver, because you can't really split them up in an event. Where are they? Again, private residences. Everything that we have done in the past how many decades has been to try and keep individuals in the community for as long as possible. And again, in a disaster scenario, this is a manufactured home, the senior community, 55 and older, that was taken out by, I believe this was Hurricane Francis. This entire community, thousands and thousands of elderly individuals, I believe the median age was around 75 to 80 years old. They completely lost everything, and they were all fixed income individuals. So where'd they go? We'll talk about that in a minute. Multifamily residences, one of the things that we also have a lot of in Florida is high-rises that are exclusive for senior populations. There's a lot of challenges associated with those individuals because they're often unable to provide for their own needs during a disaster. And just to fast forward a little bit, when Hurricane Wilma came across the very metropolitan area of South Florida, we lost power for up to 6 weeks in certain areas. When the power went out, the elevators stopped working. And so you have seniors, frail seniors, living on the 10th floor of a high-rise, unable to get up and down, and unable to get supplies, unable to get water, unable to get food. No electricity, therefore not able to refrigerate any food that they did have. So they became an important or a priority for emergency responders in the aging network that responded to them. Of course, you have assisted living facilities, nursing homes, hospitals, and hospice units. These are all sort of clumped together with respect to disaster management because these are congregate environments where you have frail elders. Hospitals I'll talk a little bit differently about, but one thing that we also learned a lot about was hospice units. Imagine a hospice unit with say 30 to 60 patients terminally ill, and then suddenly a storm comes and it wipes out all transportation, no way to get to the unit, no way to get from the unit, as well as expiring individuals and no way to provide a place for them to go. So we'll talk about that as well. And then in Florida and in many states, we have special needs shelters. Special needs shelters are designed to care for individuals that cannot be in a regular shelter. Families, healthy adults will go to a regular shelter, and they're basically taking harbor from a potential storm. Special needs shelter provides intermittent nursing services and additional services that individuals may require. Individuals that are on oxygen, individuals that require electricity. In the case of hurricanes, when we see them coming, we open up our special needs shelters at a certain point and people go there. And we'll talk about evacuating and special needs shelters a little bit more in detail in a minute. The other thing about, and I put pre-disaster because one of the things that we found with the hurricanes in Florida and in other significant events is that a lot of people presume that special needs shelters are a place to go to ride out the storm. We found that special needs shelters started to become populated after an event. People rode out the storm in their houses. Their houses were destroyed, basically uninhabitable, and so they had nowhere else to go. The hospitals would not take them because they were not needing acute care. The nursing homes wouldn't take them, probably because they could not afford or did not qualify for nursing home placement. So they had nowhere else to go. They started to go into special needs shelters, which were only designed to house individuals during the event. This is pretty self-explanatory. Individuals out in the community that are living in the community as whole individuals, these are the reasons why they become vulnerable, because they require certain things. Obviously, food, water, medications, and appropriate shelter. Health care services, home health, durable medical equipment, oxygen. A lot of elder individuals that are vulnerable require case management services, meal programs, and very specific transportation services, not just for medical supplies, but also for their daily living. They also require some level of social and or family support. Unfortunately, we did see a lot of cases where individuals did not have that level of support, and they were even more vulnerable. And the other group requiring medical services and institutional care. When an event happens, basically several things happen to vulnerable adults. If it's a catastrophic event, you're immediately going to have death and injury. And yesterday we talked about the disproportionate effect of catastrophic events on senior populations. Damage to private residences, extended power outages. And again, all of these things are playing into why these individuals are vulnerable, why these individuals have to be factored in when planning for a catastrophic event, climate change, and things like that. During several of our hurricanes and in the flooding situation, we had overcrowding of our long-term care facilities, our nursing homes, our hospitals, and even our hospice units. People took refuge in these places because they really had no place else to go, and they did have some sort of medical need or some sort of supportive need that could not be met without the support mechanisms that were in place prior to the event. There was disruption of life-sustaining services, access to medications and medical equipment. Again, power outages affected a lot of people. Fuel shortages, transportation issues. People couldn't get to and from the sources of what they needed. Very limited access to food and water. In several of our, when a disaster strikes in the United States, the Federal Emergency Management Agency sets up disaster recovery centers, and that's where people can go to get water and ice and basic provisions to help them until the power can be restored, until they can apply for aid and whatnot. In the case of elderly individuals, they were unable to go to these DRCs, and even if they weren't able to carry cases of water or ice and food up to their 10th floor apartment, which had no elevator service. Air conditioning in Florida, definitely a major issue. Frail elders are more susceptible to heat stress. And when you become very dependent on air conditioning and suddenly it's gone and it's 100 degrees and extremely humid, you can imagine. Just walking around here the last 2 days, I noticed people walking around in shorts. I'm from Florida, and you can definitely tell that I'm from Florida walking around the last couple of days, but people are saying this is beautiful weather. Biohazards. With especially water-related disasters and heat, you have mold, respiratory issues. Hurricane Katrina stirred up a lot of stuff in the atmosphere. People were breathing it in. If you already had respiratory issues, you were unable to maintain your residency in your home. Even if the structure looked like it was sound, a lot of the homes seeped in water, and then mold started to form inside the interior of the walls, and that caused a very unsafe environment for individuals. And even though the roof was intact, people had to leave their homes and take refuge in shelters because they could not be in those homes. And then, of course, with any kind of major events, there's a lot of confusion. And if you have no power, then chances are you don't have a television. And if you don't have a television, you're not really tuned into what's going on. We really push battery-powered radios in Florida so that you do know what's going on. But a lot of individuals just aren't prepared for a disaster. Tornadoes strike instantly. There's no real way to kind of prepare for a tornado that just kind of pops up. But there's always a lot of communication issues, and it's not just amongst the elder population, it's between agencies and organizations that are there to help them. And so one of the things that we learned a lot about was the fact that all of our systems were designed to work in silos, and they really needed to work together to address the vulnerable populations. I'm really going to talk a little bit more about our healthcare system, and I could go on a lot about how our healthcare system first was impacted in 2004 and how the 7 hurricanes later there were changes in policies and regulations. But there are a lot of challenges with respect to healthcare in the United States and anywhere in what happens in a catastrophic event. Your home health service providers, these are the folks that go into the home to keep the individual in the home. If they're unable to travel because the roads are impassable, because there is smoke due to a fire, if they're not able to get to those individuals, the individual on the other end is very vulnerable. In addition, the home health providers and all of the staff of all of these facilities, they're victims themselves. So the CNAs, the nurses, the doctors, their homes may have been destroyed, or their cars may have trees laying on top of them, or they are unable to get to the hospital because the snow is so deep that they can't make it. So that's another important thing that we need to think about with the healthcare system, is that the actual people that provide the healthcare are often victims themselves. Medical transportation providers, this was a big issue. If a road is impassable, it's impassable to an ambulance as well as a car. And so when trees come down due to ice or hurricanes, until those roads can be cleared, anyone requiring those immediate services on the other end are at risk. Long-term care facilities, which include like assisted living facilities, community care, retirement communities, basically groups of elder care facilities that provide intermittent nursing care. These are very popular in Florida. They are not quite nursing home level of care, but because they're so popular, there's a very large population of frail elders that live within those units. And those units are susceptible to disasters just like any residential unit. Same thing with nursing homes and hospitals. Now, hospitals, they have the advantage of being prioritized for power restoration. They usually have very elaborate generator systems, where nursing homes and long-term care facilities, they're generally on the secondary tier. Hospitals usually are set up first. But hospitals are often the automatic place where vulnerable adults will seek refuge. They think, okay, I'm not doing well, a disaster has happened, go to the hospital. So the hospitals found that they had to turn away individuals because they did not require immediate acute care. What they needed was sort of long-term or intermittent care to respond and recover to the disaster. Hospice units, a real challenge. Again, not designed to operate as an individual entity. So you can imagine you have individuals expiring on a daily basis, no transportation in, no transportation out. You've got distraught family members that are there taking refuge as well. I really don't need to go into it much further, but you can imagine the challenges associated with dealing with a hospice unit in an event. And of course, our special needs shelters. In Florida, up until the 2004 hurricanes, special needs shelters were set up to operate for 72 hours. One storm sat on top of us for 72 hours while the special needs shelter was open. We found that special needs shelters ran from 72-hour philosophy to we need to be ready to be open for about 2 weeks. And in Florida, our special needs shelters are basically school gymnasiums that are converted into large rooms that can withstand hurricane-force winds, that have cots and medical services brought in. Food, water, medical services, and cots. That's what a special needs shelter is. Oftentimes, our special needs shelters are elementary schools. So imagine a 90-year-old individual with an oxygen tank using a toilet designed for a 5-year-old. And then being in there for over 2 weeks. And we had mortality in our special needs shelters, and there was no plan for that. Again, they were designed to be opened up. Everyone goes in, the storm passes over, everyone goes home. Well, when everyone went home, they found that they didn't have their home, or that the home had no power, so they could not plug in the electrical equipment that they needed. Or they had no air conditioning. So what did they do? They went back to the special needs shelter. And those that were lucky enough to survive some of the impacts that some of the storms caused, they finally gave up and left what was literally rubble of their home and went to the special needs shelter because they had no place else to go. They didn't have the financial resources or the ability to, or the requirements to go to a nursing home or an assisted living facility or even a hospital. I wanted to quickly talk about evacuations because a lot of this was brought up during Hurricane Katrina. This is a big issue in Florida. And this is a real challenge for emergency managers. When do you say evacuate? When do you tell 1.5 million people to leave the city? And there's certain factors that have to be thought about. Number one, if you pull a major evacuation of a major metropolitan area, you are going to cause death and injury. Traffic accidents, various different things, the stressors of people evacuating a city, you're going to cause death and injury automatically. In fact, in Hurricane Rita, the greatest loss of life was because they evacuated. There was a traffic jam on the highways out of the city. One of the buses had a whole group of elders from an elder community. On top were the elders. Down below were all the oxygen tanks. They had a brake failure, overheating. 26 people, I believe, lost their life in that fire. The question to evacuate is really, is it better where you're going? And not always are people willing to leave their homes. It doesn't matter if you say, listen, your house is going to be underwater within the next 24 hours. You need to leave. People, especially older individuals, are reluctant to leave because they're afraid that if they leave, they're never going to come back. If they leave, their items are going to be stolen or taken, or they'll be looting and whatnot. And the question, again, comes back to what are the odds? Is it better for me to stay here, or is it better for me to leave? And I want to show you this diagram because this is what Florida's hurricane activity was in 2007. And of course, over on the far right, I believe I have a pointer here, this is Miami, Fort Lauderdale, West Palm Beach. This is Boca Raton right here on the edge. And then over here is Tampa. This is Hurricane Charlie. In the middle of the state, there's nothing but alligators and swamplands. So you've got all your population on this side, all your population on this side. This is fairly rural all through here, and nothing pretty much here at all. Well, when Hurricane Charlie was coming in, it was coming in pretty quickly. It was headed directly towards Tampa. Tampa is like New Orleans. It sits below sea level. Anyhow, you have two main arteries, up, down, and then one road across. And basically, we decided we're going to evacuate Tampa. So everybody went south or east. And what happened just before Charlie made landfall, it turned. And instead of going into Tampa, it hit where most people took refuge, south of Tampa. So we actually sent people into harm's way as opposed to out of harm's way. I seen my time's up, but that's okay. It's my last slide. Second to last. Again, varied levels of personal preparedness has a lot to do with how the outcome of these events are going to be. Willingness to evacuate and seek assistance and or shelter varies from person to person, community to community. We found that there was a lot of inconsistencies with how agencies work together, whether or not they spoke the same language, whether they understood which each other's roles were. There were not real great policies and procedures focused on healthcare providers and their ability to move individuals or care for individuals during disasters. Sheltering issues, backups plans were not quite as forward-thinking as they should have been. Again, 72-hour plans versus 2 weeks. And we also found that the elderly really needed to have more communications targeted to them because they are a different population and not all elder individuals are vulnerable individuals. And one other thing I want to leave you with, even if you come up with the best plan, it's not always the best plan. Thank you.
If we could have the panelists back up to the front to sit here at the front. Dr. Stone and Gloria. Okay, so really the purpose of this session, as you could probably tell, is to build upon the superb presentation that Dr. Corvalin gave us this morning and to lay some of the groundwork for the rest of the conference for the next 2 days. So some basics on climate science, some basics on gerontology, and some sort of real lived examples of how climate change impacts on older adult populations. So we're going to open up the floor now to questions and or discussion. And I would ask you if you have a question, raise your hand. Bobby Sams will bring you the microphone, and to stand up and perhaps state your name and where you're from.
Good morning. Thank you. Michael West in the United States. Question to George. I spoke yesterday about the disaster after the disaster. I think it would be instructive to the audience if the population that got marooned in the shelters and the work we did with the federal government and just the pulling of teeth to get the resources, the commitments you made to the industry to accept these people, and it was not a pretty picture, and maybe that would be instructive for them to hear a little more about that.
What Mike's referring to is in 2004 when Hurricane Charlie hit, we had several hundred individuals, frail elders, that were basically marooned in a couple special needs shelters. They were O2 dependent, electrically dependent individuals whose homes were completely destroyed. Charlie came in to a population where the county, 50% of the population is over the age of 65, one of the most senior counties in the United States. The federal government, the response agency, came to us and said, what are we going to do with these individuals? And because they are not familiar with Florida healthcare system, they look to us to give them guidance. And so what we did was we said, okay, what are their needs? They need housing, they need meals, and they need intermittent nursing care or services. And so what we did was we convinced the federal government to do something they hadn't done before, and that was to take that vulnerable population out of the special needs shelters and move them into vacant units within the long-term care industry. And it actually worked quite well because once you get them out of the special needs shelters, they are able to begin to recover, and there's enough time for all the programs and services that are available to help them recover to kick in. And not only that, it allows the special needs shelter to open back up as a school so that kids can go back to school and so their parents can go back to work and get everything going again.
Other? Goodness. Yeah.
Thanks. Tim Takaro, Vancouver. I was interested in the aging network that you described in Florida, and I was particularly interested if there is anything equivalent, Gloria, in Canada. My understanding of this network is that it enables government officials in the event of disaster to contact their vulnerable population. Do we have anything, is that indeed the way it works, and do we have anything like that in Canada?
Well, I'll just add to that. Prior to 2004, the federal response agencies, Department of Health and Human Services and FEMA, were not connected to the aging network at all. It's not until that event, Hurricane Charlie, where they said, you know, we have this huge senior population that's been impacted. We know nothing about them. We're not even from this state. We're from all over the country. And so where are they? How does it work? That's when the aging network was brought together with the Federal Response Agency. And today, they work together. Anytime there's a disaster, immediately the Elder Aging Network is brought to the table. I don't know about Canada.
Well, since 2005, there is a group of, an international group that has been meeting under the aegis of the Division of Aging and Seniors of the Public Health Agency of Canada. And Patty Gore is here from that division and has been involved with us. Maggie Gibson is here. They're at the back. And what we have done is to bring together the gerontological community and the emergency response people in Canada. So yes, the groups are talking to each other and have become aware of the fact that in a disaster situation, you better know where the seniors are. The hardest ones to get to, so people that are in care facilities, you know about. People that are getting home care, you know about. It's the frail elderly. See, the 5% in institutions, there's another 10% with major restrictions on their mobility that are frail people being cared for at home. And that was a group that George mentioned. So those are the ones that are hard to get to, and we're still working on it. We do not have in this country area agencies on aging like they have in the USA, where there are targeted agencies that are geographically distributed around the country, and it's their job to sort of bring some of these groups together.
Is that a provincial responsibility then?
I would think so. And so, you know, we need to be talking with people on the ground. That's again part of the reason why we wanted to have this event. We've been blessed in Canada that we have had disasters, but with little loss of life and mostly property damage. But that doesn't mean that things are going to stay the same for the future, particularly with climate change. What's very clear is that in this country we have seen an increase in climate-related events. If you go to the website of Environment Canada, you can pull the graph off yourself and you'll see it. So we need to be preparing now for the future and starting to get these things in place so that should we have something that we would be able to cope with it. The closest we've had was SARS, and I think we did better in British Columbia than they did in Toronto in terms of dealing with it. But Vancouver's in an earthquake zone. So that's a possibility. Not climate related, but it's a disaster situation.
Thank you very much. Professor Torsky, I would like to ask you, all these programs that you mentioned about the elders on account of climate changing are covered by the state or by the government? Because this is my question, a very hard question for me, because I have to refer to my country when I come back. And another question I have for Professor Goodman. But if you want, yes.
And just to clarify, you're referring
Yes.
to programs and services to help individuals after a catastrophic event?
Yes.
It's driven top down, and then also it's a combination of federal assistance, state assistance, and then private sector and or not-for-profit sector assistance. We're very fortunate that we have the structure of the federal government to push resources out, but they have their limitations. They push food, water, they'll pay for certain things, but then the state is then charged with assuming most of the costs of providing assistance beyond that. It depends on specifically what it is. If you lost your home, you have no insurance, the federal government will give you up to a certain amount, and that's it. But all the other things, you may need to turn to the Aging Network, the programs and services that the Aging Network provides to help you recover from a disaster.
Okay, thank you very much. And Professor Goodman, I would like to ask you, do you plan or do you have some idea that after so many changes of climate, perhaps we'll reach, instead of longevity of aging, to a shortgevity of aging, or is out of the question or that?
I'm not sure I understood your question.
That after all these changes of climate, all this abrupt of climate, perhaps will be so dangerous that instead of longevity, to talk about shortgevity in the near future.
Okay, I'm an optimist and believe that people will adapt if they have the opportunity to prepare ahead of time. And I would invite you to come to some of the symposia and to some of the paper presentations where we actually talk about some of the projects that are going on in this country now to try to assist seniors. It's a self-help kind of idea, because we each, to the extent that we can, need to be worried about ourselves and how we will deal with a disaster situation. If you make the preparations ahead of time, then you have a much stronger chance of surviving. And it's the very extreme situations where you get very high mortality and morbidity within the very frail population. But for, like I say, for the other 85%, you want to make it possible for them to adapt and survive.
We have time for one last very quick question and answer.
Okay. It's a question of emphasis. What we've heard from the panel is very much an emphasis on issues around disasters associated with, say, hurricanes or extreme weather conditions. Now, while these are very important things to deal with and certainly hit the media, I'm guessing that the real impact on older people is not so much the disasters, but the small changes that might occur with climate change. You know, small temperature rises, which are going to increase the risk of, say, respiratory disease, etc., etc., and that it's these issues which may be the real ones that we have to deal with. I don't know whether Gloria or John may have some observations on that one.
Well, again, I would suggest that people adapt. People will adapt to the small changes. So if it's a few days of hot weather and we follow some of the Health Canada directions. We go and get ice, we make sure we've got an air conditioner, we go to a cooling station, that we can cope with these things. So I don't see it as a major killer or a way of reducing the seniors' population.
It's a very important point you made. It's been a part of my concern with being involved in this, is that there has been so much focus on the extreme events, climate. I mean, and for obvious reasons. I mean, it's easiest to understand, and we have lots of examples that we can draw on. But I'm sure there are going to be lots of other impacts of climate change on older and aging people. Things, for example, changes of disease vectors and the like, and where older people, for all sorts of reasons, may be more vulnerable because of existing health conditions, because of lack of resources, of poverty, malnutrition, and what have you. So I think it's really important to remember that there are other potential impacts than the simply ones.
I was just going to say that I think some of those issues will be sort of drilled down a little deeper into in some of the coming sessions. So study your program carefully and the abstracts, and some of the sessions are running concurrently.